about anatomy of the coccyx and about coccyx imaging studies. Basically, this is someone who I've quoted in things that I've published for years before meeting Jason this past June at the International Coccyx Pain Symposium in the Netherlands. And he was gracious enough to agree to talk to us this evening about anatomy of the coccyx and imaging studies of the coccyx. So without further ado, Dr. Owen.
Thank you, Dr. Foy. So thanks for the opportunity to speak today. As Dr. Foy has mentioned, we met at the Coccyx Symposium last year. There aren't many people that study the coccyx. But as physicians at this clinic, you probably have an idea of some of the problems both physicians and patients face when trying to manage coccyx pain. So I'll start with a case study from Dr. Foy's book. I like to start with it as it shows the importance of understanding precisely the anatomy of the tailbone pain. So this is Jessica. She's a young woman, and she was trying to picture in her mind what was causing pain. She heard many people had low back pain, but understood that pain was usually higher up. Low back pain, that is. Her pain was much lower down. She did not know internal human anatomy very well, and so she searched online for images of back pain or buttock pain. And initially, most of the images were of lumbar or lumbosacral spine. She could see that those images showed areas higher up compared to where she was having pain. Eventually, Jessica came across some images of the tailbone at the lower end of the spine. She immediately knew that was the site of her pain. She smiled with satisfaction at her discovery. And so knowing the anatomy of the pain and where it's coming from is really the first step in finding the underlying cause and the best possible treatment. Okay, so the whole point of the talk today is to discuss standard X-ray, your standing lateral view. It's the view most people get if you're not at this clinic. And to understand that, we'll talk about the studies that have been done in the past, and we'll talk about what we know and what we don't know. So the talk will be split into 3 parts. The first we'll discuss bony anatomy as seen on imaging studies. The second we'll go through a case report, and the third we'll talk about what we're currently working on. Okay, so why study the coccyx? As we say, coccyx pain is difficult to treat because it's not a common presentation and is still considered a niche topic. Nevertheless, there are enough people suffering from coccyx pain, as you guys know. Actually, yeah. And so recently there was a paper published saying that emergency departments should stop doing x-rays of the coccyx. And they're basically saying that we don't know how to manage these patients, go home. So Dr. Foy wrote a very detailed letter to them and detailing all the problems of that approach. Particularly the fact that sitting x-rays, dynamic x-rays, are not accepted mainstream. They're not part of the CPT of the current procedural terminology for radiology. It's difficult to obtain sitting x-rays. So clinicians still only do standard x-rays. So going with that, I'm wondering, what exactly does a standard x-ray show us? Okay, here's a brief who's who of contemporary coccyx anatomy researchers. It all started in '83. They were the Italians. We've got some half Italians in here. So they were really the first. They looked at normal coccyx x-rays of 60 men and women. The paper was the first to classify curvature of the coccyx into 4 types. However, this typing is not that useful, and I don't think you use it. Dr. Main doesn't use it. So the next big study was by Dr. Main in France. So I spent a month with him before coming here. And he really contributed. He came up with the idea of dynamic X-ray, published in '92 actually. And he's published a lot more stuff. And then you have the Koreans in '99. They kind of came up with the idea of an intercoccygeal angle and how to objectively measure it rather than using types. Again, we don't really use that so much. In '07, there was a Turkish study, and they came out with a type 5, which is retroversion, where the distal end of the coccyx extends backwards. You guys call it pseudospurs. And so, yeah. And also in '07, Grassi, an Italian, did a MRI dynamic study looking at defecation, movement during defecation, and they found that during defecation it moves more so than between standing and sitting. And 6 years ago I looked at a population, about the same number of normal versus people with coccyx pain. And our goal was to just basically establish any in vivo anatomy of the coccyx bone. How many bones is it? How long is it? How curved is it? And what degree of joint fusion is available? We're trying to figure out, are there any demographic factors that predispose a certain population to coccyx pain? Okay, one of the difficulties of looking at coccyx X-ray is determining how many segments make up the coccyx. And so you know where the sacrococcygeal joint is. So have a look at this image. It's a T2 MRI. What do you notice about it? I don't know, it's quite... I mean, the title kind of gives it away.
Is there a transitional vertebrae?
Yeah.
There's an L6.
Yeah, so it's difficult to just tell from the lateral view. I have difficulty as well. And basically, you can have either sacralization of L5, so L5 being a part of the sacrum, or lumbarization of S1. So the former, sacralization of L5, so L5 becoming part of the sacrum, is present in 25% of people. So it's very common. And the best way to tell is using AP. There's a guy, his name's Castovi, and he came out with some classification depending on how much fusion you can give it, type 1 to 4. But for purposes of counting the coccygeal vertebrae, it's very confusing, as you can see. If you count L5 as S1, you will be one vertebrae off. Here, we have a middle and right image. You can see the same happening in the coccyx. So the coccyx can become sacralized. It is rare. In my study, we found unilateral fusion in 5%, bilateral fusion in 7%. In fact, there isn't currently a classification system for sacralization of the coccyx, but the same thing happens here as it does in the sacrum. And whether this can be a source of pain hasn't been studied. In the lumbar region, you call this Bertolotti's syndrome. So maybe it can cause pain. That's something to think about. But for the purpose of an injection, Dr. May, he doesn't really count the numbers of the coccyx. He just uses dynamic X-ray, and he'll find the mobile joint, he'll inject in there. But I think in this clinic, you guys make a point to include the exact joint. I think this is nice for the patient, as it gives a more accurate diagnosis. Right. So we know there's more women than men who get coccyx pain. Is there a reason for this? That can be explained just from the anatomy. So we know the pelvis is the part of the body that has the biggest gender difference, and so is the spine with lordosis and kyphosis. And the coccyx is the pelvis and the spine, so maybe there's something there. So we looked at a number of segments between men and women, the most common being 4 segments, no difference. Looked at length. Men, without doubt, have larger coccyges. This is not associated with height, as you might think. So what does that mean? Curvature, men tend to have more curved coccyges. In fact, women, because of their childbearing potential, their sacrums are wider, straighter, and shorter. And so it makes sense that the coccyx follows suit with the sacrum. One limitation with our study, we didn't have information on parity of the women, so this could be important when it comes to curvature. All right, so in terms of fusion, sacrococcygeal fusion is very common. Sacrococcygeal joint fusion. In our study, it happened, more than half of people had it fused, and there was no gender bias. Spurs or spicules. This was relatively common in the normal population. A quarter of people have it. Again, no gender bias. Pseudospurs or retroverted coccyx, they were present in about 10%, 11%, and there was no gender bias either. Right, so we've just talked about normal anatomy. Now we're comparing women, because women make up most of the population of coccydynia. We're comparing women, normal women, and then women with coccyx pain. This is, which slide is this? Right, so we say women have straighter coccyges. In our study, we found that if the women had coccyx pain, they were more curved than normal women. We found that had less sacrococcygeal joint fusion, half that of normal women. Spurs were more than twice more common in women with coccyx pain. And when we took our cohort of coccydynia patients, split them into their hypermobile, rigid, or dislocation groups, we looked at it again. And as you would expect, in the hypermobile group, there was less intercoccygeal joint fusion than all the other groups. Maybe that's why it's more mobile. Rigid coccyges, there were more pseudospurs in rigid coccyges, and they were straighter. And the patients tended to have lower BMI in this group. In fact, it's not uncommon for someone who's lost a lot of weight to come in with coccyx pain, either from surgery or diet. And usually you'd be thinking of spurs in this scenario. And when it comes to the dislocation group, we found that patients who tended to have higher BMI. Right, and so I did another search on current literature. So after I published my study, there was 5 more studies done, and did they agree with me? So this one was from Kuwait. In an Arab population, they looked at 200 scans, just at normal individuals. And everything was the same, except they found that commonly it was 3 segments rather than 4 segments in the coccyx. But we've said it's hard to count, and maybe they didn't take into account. Who knows? There were 2 Korean studies in the same year. And basically, the only difference between their study and my study, the first one, they said older women had straighter coccyges. What does that mean? The second one, they said that women had straighter coccyges, which is what we said, and fusion was less. Slightly less than what we reported. And then there were 2 Indian studies. That 4th one is not really an imaging study, they just look at cadavers. I thought it was interesting. You're looking at discs between the joints, and they found that in the coccyx, 87% of the time there wasn't a single disc between any of the bones. So to answer your question, if there is a movement, probably synovial. If there's no movement, probably fused or a fibrous joint. And then that last study, it wasn't very good, so I won't talk about it. So, what does this all mean? Are there anatomical differences between the genders, or even between ages, that predispose them to coccyx pain? The answer is probably there isn't any appreciable difference, a difference that would impact your clinical practice in a significant way. But the information is still useful because patients ask it all the time, and you want to have evidence to explain it to them, because people think about those things. What we can say, in a hypermobile coccyx, there is less fusion, that's why it's hypermobile. In a rigid coccyx, you have more fusion and more likely to have a pseudospur. And if the patient walks in and they look slim, you'd be thinking about rigid coccyx most of the time. If they're on the bigger side, you'd be thinking about dislocation, but obviously there are overlaps, and this is just one way to guide your thinking. Okay, so that's what we know. And here I have a case report. Right, so patient comes in, 19 years old. She's had persistent coccyx pain for 4 years, and it was traumatic. Someone kicked her in the back. I don't know why, but someone kicked her in the back. The pain was while sitting. She has trouble walking, and she wakes up at night from the pain regularly. And this is affecting her school. She's had 3 X-rays, a CT, MRI, and the radiology report normal, 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 across the board normal. On examination, she has point tenderness like this on the sacrooccipital joint area. Internal exam was not performed. There were no other signs that we could find. So she's brought in all these X-rays. We had a look, and this is her X-ray that was done recently. What do you guys think about that X-ray?
She's at least one or two patent joints. Does she have a, is there a compression of that one you're pointing at? It's more of a triangle rather than a square shape
it looks funny.
to it, yeah?
Yeah, but yeah, I mean, we just looked at it and like, that looks weird. And so we're like, okay, do you have any other X-rays? So she had the X-ray she did on day of injury, and that's what it looked like.
Oh.
Looks a lot different, right?
Yeah. So she's lost the rectangular shape that she had on her initial X-rays, and now she's gotten more of a triangular.
Yeah. That's what it looks like. And then this was like, pardon the quality, but this was 2 months after the injury. So we put everything side to side. That's the one from recently, and that's what we got. So if you can't really see it here, but if you zoomed in on this one, you'd see a transverse line that was completely missed. Transverse fracture line, the bone wasn't displaced, and assuming this is CO2, that's CO3, the joint is anteriorly dislocated. That dislocation sort of corrected itself 2 months later, but that's kind of pushed in on each other. And then here it's just disappeared. How do you explain that? So the fragment's gone, there's a defect in the second bone, and the dislocation is corrected. Yeah, so we've just avascular necrosis due to compression, nutcracker fracture. So let's discuss what's happening. So AVN has been reported in 2 cases in the past. They confirmed it on histology, but it's never been shown with imaging like this. We can't prove it because we can't do it histologically, but what is the alternative? You know, what else could it be? So we did a bit of a literature search, and it's also higher up in the spine. It's called Kummel's disease, or post-traumatic vertebral osteonecrosis, pseudoarthrosis, delayed vertebral collapse. There's a lot of names for it. And in Paris, Dr. Main talks about this nutcracker fracture quite a bit. He describes it as one of the most severe forms of a coccyx fracture, and it involves 2 opposing forces that act on a middle fragment, and it often dislocates that fragment posteriorly, depending when the forces come in. So this case report kind of highlights the one reason why you would do a baseline standing X-ray. So you can document pathology over time. In this case, there was bony remodeling, and without that first X-ray, we might not have known what happened. Right. So that's done with the case report. We're on to the final section. So I'm currently still working with Dr. Main, and Dr. Foy is advising on this, but so I've got access to Dr. Main's database, and just with preliminary data, in the last 10 months we've had 273 patients, and we've only included the traumatic patients, and 85% of them were female, but I didn't put it here. But so a large portion of those 273 were just coming in for injections. We didn't actually do a dynamic X-ray. So we took the dynamic X-ray population, and then we took just the trauma patients, and that was about 50, over 50, closer to 60. Mostly females, 9% of them, so all trauma, but 9% were childbirth, and the symptom duration from clinic to onset was about 31 months. And then I take all these scans, I blind them and give it to Dr. Main, just the standing x-rays, and he looks at the blind, and he tries using radiological signs that no one's really have reported before. He tries and just looks at the standing x-ray and tell me if it's going to be hypermobile, or if there's a fracture, or if there's a spur. And then we compare that with the eventual diagnosis and see how predictive those signs are. And then once we've got the predictive value, we can put it in, I'll give it to my statistician. She'll figure out how many patients I need in total to have significant power, and then I go and find those patients and complete the study. So yeah, working with Dr. May and Dr. Foy, combined between them, they have 50 years of experience working on coccyx pain. And collectively, they probably know more about coccyx pain than the rest of the world, you know. Or what's that rule? Pareto's principle, whatever. You know, 2 people know half of what the world knows, and then the rest know the other half. And yeah, so and because they've worked for it for so long, I think reflexively when they go through a standing X-ray, they've got a checkbox in their head, and they're sort of saying, yeah, I think that's the joint, without even looking at a dynamic X-ray. So I'm trying to tease that out, really. So I've talked about that. So what are these signs? So Dr. Main has 3 signs. He looks at the obliquity of the joint, so see how it's like oblique. And he looks at this distal part, and if it's straight or even extended, and that's his signs. And just using these 3, the preliminary data show that he was able to predict 70% of hypermobile joints just on standing X-ray. 7-0. And I think that's pretty good. I didn't know what to expect, but that's pretty good. I think he knew he would get that number actually. And so I spoke with Dr. Foy, and he's suggested doing more stuff. He's saying to not just predict if it's prone to dislocation, but also to say which joint it is. So say if someone can't do dynamic X-ray for whatever reason, they can use these signs to predict which joint is the unstable joint and do an injection. And that's better than doing a blind injection where you don't know anything. And Dr. Foy has his own method of, so that's another standing X-ray. So Dr. Foy looks at the joint height. So if it's sort of high, more increased than the others. He looks at the obliquity of the joint. Indentation, would you say that's an indentation? I don't know. Not really.
Not from here, no.
Okay. And arthritic changes, a little bit there, but maybe not that obvious.
And then the 5th point would be if there's a slight listhesis, which you would
is,
say that there is in this one.
And I have seen the dynamic X-ray, and it is this joint, and it goes posteriorly. So I think this is something. I think you can see quite a bit on the standing X-ray. But we'll see what the study shows. So this is the last slide. So let's say we were to come up with an algorithm on how to go through a standing X-ray. A good place to start would be saying, okay, is there a transitional vertebrae? Because you want to count the number of coccyges, you want to know where the SC joint is. You want to orientate yourself. Next, obviously look for a fracture, because it's the first thing you look for. And you want to use high magnification, as we saw, fractures are easy to miss in the coccyx. Next, obviously look for spurs, pseudospurs. Be thinking of a rigid coccyx, look at joint fusion, how straight it is. And then you do the checklist once the study's been published. If it's good science, you can go through your checklist of, is this an unstable joint? Is it hypermobile? And finally, like all radiology, you want to look for other stuff, so like calcification, any soft tissue abnormality in surrounding tissue, any loss of bone to indicate tumor, such as a chordoma. That's one slide. So in conclusion, right now, most people don't really do dynamic X-rays. And so, should the standing X-ray still be done? I think so. I think it's too good of an opportunity to pass to do an X-ray, say, at the time of injury. And it's already a difficult thing to manage. Why make it more difficult? we need to know what's going on, and any information is good information. And this new study hopefully will give clinicians a system for examining standing X-rays. If it comes out that the signs are completely useless and non-predictive, then we only highlight the importance of dynamic X-ray. Thank you.
That was great. I like the idea of the approach that you're taking, because the approach that I've been taking is when I lecture, has been to encourage places to start doing sitting versus standing X-rays, to do the dynamic X-ray.
Mm-hmm.
And I basically have been completely ineffective, despite working on this for about 20 years now, completely ineffective at getting places to do them. So when I lecture at, other places in the city and other academic, medical centers around the country. So kind of what I like a lot about your approach is basically to say, okay, well, if they're not going to learn how to do the sitting versus standing X-rays, what can they at least learn from the from the X-rays that they are already doing?
Yeah.
And if they can, and if we can come up with a criteria that will help them to be accurate, let's say if it is 70% of the time.
Yeah.
Well, that's 70% better than what they're doing now.
Yeah.
Yeah. So although not perfect, although I still would say that the sitting versus standing X-ray, of course, would be more the gold standard for radiologic, diagnosis of hypermobility, dynamic instability. If there's a low-cost, more user-friendly approach, that's a plus. So very neat. It'll be interesting to see how it turns out.
And I feel like if the radiologists start to trust the research more, then they'll be more open to dynamic X-ray eventually.
Right, like the right.
If this
this could also be a stepping stone.
Yeah, that's what I'm thinking.
That in the let's say if it's 70% of the time where they see a suspicious looking joint, then they'll say, oh well, we should actually, if the patient is still symptomatic, perhaps have them come back and do the sitting X-ray.
Yeah.
And then, frankly, after they do that for a couple of years, they'll realize it actually would be much more, time efficient and cost effective to just add the sitting X-ray at the time of the initial, whenever the initial lateral view in the standing view is being done.
Yeah.
So it may be a stepping stone to having them accept the sitting X-ray.
Time will tell.
Yes.
Any more questions?
I did have a question regarding the curvature of the coccyx in female patients, and so I found it so interesting that you pointed out in the normal population that women tend to have less curvature compared to men. But then in the pathologic population within women, they had more curvature. And like, when exactly. And like when I first heard it, I was like, oh, okay, it makes sense. Women are more prone to coccyx pain, as you said, and they have less curvature, so maybe that would make them more prone to have injuries, and maybe prone to, say, hypermobility or any forces striking that region, but then pathologically they have the curvature. Now is that, I guess maybe is a question of like chicken and the egg, do they have the pain because they originally had a more straight coccyx and then became curved? Because of like other factors, that you were looking at on these MRIs?
This is my litmus test to see when people are listening. So, because I don't like that part of the data, but it is what it is. And because if men have that curvature to begin with, why don't they have more coccyx pain? If it is the curvature that's...
But it's curved and long, right? It's longer too, so
sure.
That makes a difference.
So maybe the longness... I can't really answer your question. I don't really think it matters, actually.
And you mentioned regarding the parity, and that was actually a really great point because, well, I guess, so what was like the characteristics of your study in terms of like the age of the patients? Were they like primarily women?
Probably between the third and fourth decade.
Okay.
So, like post childbearing.
Mm-hmm.
say. Yeah.
So, okay.
But again, there's too much bias in there, and the studies are not coming together. Everyone's kind of saying different things. And really, I've kind of given up trying to figure that out because I'm just not sure if it's going to lead anywhere. Maybe it's just anatomical variation, and it has nothing to do with coccyx pain. But who knows? Yeah.
Right, yeah, I noticed that as well. It's a great point, Paul. The, intuitively, if you're looking for people who have coccyx pain with external trauma,
Yeah.
you would think that patients who have a tailbone that stays kind of straight or somewhat extended, like a retroversion or pseudospur, type, that those people would be more at risk because as they sit down, fall or sit down hard on a chair or an arm of a chair or anything, their tailbone is sticking further out than somebody who has a forward flexed coccyx. So they're going to have sooner contact and more likely to make contact.
Mm-hmm.
But then yes, but then that wasn't what was seen in terms of women who had the more forward flexion were more likely to have coccyx pain. Flip side from internal trauma, from thinking childbirth in particular, you would think the more forward flexion you have, the more that the tailbone is sticking, sort of abutting into the birth canal, and therefore it's more in the way. So if it was straighter or more extended, theoretically, at least, it's it's less prone to trauma. But
That makes sense.
but it's but sometimes the things that make sense, the data doesn't always bear them out.
Yeah, because that's why you think, they always describe during childbirth, they hear a crack and then they see a scratch on the baby's skull or whatever, and then the doctors say, it's normal, it's nothing. But is it an abnormally ventral coccyx? Because the baby does go through there. It's part of the pelvic outlet. So I'd say so. If you're a woman, you're young, you're about to have a child, and you have a ventral coccyx, sure, it's more prone for damage internally. And then if you have very straight pseudospur type things and you are very lean, then microtrauma on a chair or bicycle riding.
Thank you.
Okay.
Yes.